also the clinical director of Transplant Infectious Diseases Program, where he focuses on the clinical care and quality improvement in immune-compromised hosts. He participates on several regional and national committees dedicated to the management and prevention of infections in transplant recipients. He's also active in medical education as a clerkship director for their internal medicine. He's a member of the American Society of Transplantation Infectious Diseases Community of Practice Education subgroup and the IDSA Medical Education Community of Practice Teaching and Learning Resources work group. He has particular interest in innovation, including gamification, in which he received an educational grant to explore the use of gamification in digital education across multiple specialties. He has presented and published extensively on topics related to medical education, as well as infections in immunocompromised populations. So please welcome Dr. Walker as he speaks to us about pulmonary infections in immune-compromised hosts. Thanks.
Well, thank you again. And I really, it's quite an honor to be able to join you all and to approach this topic. I think the vision of this talk, it's one that I slightly modified from something I kind of developed for our internal medicine residency. And a lot of it, it's supposed to be a kind of a practical breakdown of how to start approaching infections in immune-compromised patients and specifically pulmonary infections. And I think you should always start with the need to know, why is this important? And I think for a while, people would think about these sorts of topics as being quite niche. But in actuality, the number of adults who are immune compromised is growing astronomically. I mean, in the last decade, the number that at least self-reported as being severely immune compromised went up by several percentage points. I mean, just looking at, we've over 40,000 solid organ transplants, 25,000 stem cell transplants. That's to say nothing about CAR T and BiTE therapy and all the other newer therapies that are being developed. A lot of patients receive chemotherapy for malignancy each year, have complications related to that, as you know. And then the number of monoclonal antibodies that keep coming out, that keep filling our Jeopardy talks and other things. There's a new one, it seems like, each week. And oftentimes, of course, the appropriate studying for safety is done, but until you release it into the world and kind of see how it what sort of infections you see in different populations, it's sometimes hard to predict how these targeted antibodies are going to affect the overall immune system. So I give that caveat to say that actually a lot of the population we care for is immune compromised. And I would imagine this is true for you all. It's definitely true here. In the state of Alabama, we have about 14,000 solid organ transplant recipients. We have one transplant center. We have about 10 ID docs that specialize in this. Almost all of these patients are receiving their care primarily from their local primary care doctor or their local hospital. When they're shortly post-transplant or shortly post-major event, they may follow at the large regional academic medical center, but more often they're following locally. And so I think it's an increasingly important topic for everyone to know about. And so the purpose of this talk is to be kind of practical, to give a few case examples of some types of pulmonary infections. So we're going to kind of focus on thinking about the lungs, but I'm going to try to give you some framework on how to think through infectious risk in these populations. And I will honor your time. And so I think have the flexibility to do that. I have several questions written into this to kind of prompt you. I won't go through the process of trying to do a response in this sort of format and with our time, but I do think it's helpful from a medical education space to just think about what would I do. So I ask you to kind of commit in your mind, even though I'm not going to make you hold up your hand as to what you might want to do next. So we'll start out with a patient, 65-year-old kidney transplant 5 years ago. So therefore probably no longer following closely with the transplant center. They may see them once a year. They called in due to a new productive cough and low-grade fever. They had some pleuritic chest pain, some abdominal cramping, went to an urgent care x-ray, said that there was an infiltrate, so they got antibiotics for that. And she wants to know, is this sufficient given her history of transplant? So she's asking her primary care doctor, is there anything more I should do? What should I do next? And I have a feeling this is a sort of call that might make you feel a little nervous if you're, the internal resident taking care of this patient. If I took out the kidney transplant at all, just said this was a patient with hypertension, um, you would have a lot more comfort in knowing how to manage this patient. And so I think, oh, sorry. I think knowing, I was making sure my slides were showing too. I think knowing the history of transplant makes you think this is something I need to think more about. This takes you from that type 1, that quick diagnostic reasoning where you may have an easy answer, to more of type 2 thinking, where you're going to really try to think through what are the nuances. Maybe I'm going to look up a review article or go on Up to Date or fill in the blank to get a little bit more information. So that's what we're going to do today. We're going to talk about that approach, and we're going to define, we're going to do that through comparing and contrasting some illness scripts. So the other thing I want to point out is there's a paper from the Lancet, sorry, that shows incidence of respiratory infections in various populations. And I just want to, or respiratory events in various populations. I want to show you how prominent this is. So if you talk about, I mean, if your center cares for patients with acute leukemia, over 50% of patients will have an acute respiratory failure during that management of their leukemia. Of course, lung cancer is also fairly prominent as well, 25 to 30%. So I think recognizing the frequency of these events is important versus some of the other groups like kidney transplant, et cetera, which you see much less frequently. This Lancet article I reference a few times. It's one of my favorite to share with residents. That has some beautiful tables, beautiful imaging, and it kind of is a good resource when you start thinking about these questions. So I'll give you a case. This is a patient I took care of, 65-year-old with a prior splenectomy on NCLL with the anti-CD20 monoclonal antibody and a tyrosine kinase inhibitor, who presented with fever, rigors, dyspnea, and a productive cough. And so I want to start by focusing on what's the immune deficits. So they've had the splenectomy, they have leukemia, and they have they're on an anti-CD20 agent for that, which means their B cells are really wiped out. And so I think just a very basic framework, and I teach the first year medical students, and they have just had immunology where they get into a lot more detail, but a very basic framework, thinking about what your B cells do, they make antibodies. And so when we have taken those antibodies are, of course, addressing things outside of the cell. They're secreting into your respiratory tract, your GI tract, to kind of prevent those sorts of infections. They're also addressing certain pathogens that we know of that have virulence factors that help them to overcome the immune system, like capsules. And so you may remember back to if you studied for step 1 and first aid, etc., they would have a nice mnemonic for encapsulated organisms, which are things that we really worry about in patients with this sort of B cell deficiency. And kind of the biggest ones that we highlight are strep pneumo, H flu, and Neisseria. We highlight them because of their virulence. These are scary pathogens. We also highlight them because we can vaccinate for them. And so these are ones that for the prior splenectomy, for some of the agents that they're going to go on, you would ideally have prior vaccination. But of course, with the anti-CD20 monoclonal antibody, that prior vaccination is going to be, the impact of it is going to be somewhat limited at this point. And so again, if we come back to our patient, we add on some labs. So now we know that they have a prominent leukocytosis, they have a left shift, they have lactic acidosis, they have an AKI, they're very sick. And so considering what we've just discussed, considering the time course, etc., this pretty rapid onset, are you concerned for viral, bacterial, fungal, parasitic? What are you expecting? I'm hoping many of you with the left shift and the acute onset and the preamble are thinking bacterial. And if I show you this image, I hope that actually helps to affirm your suspicion. So what you see here is very much a lobar pneumonia with dense consolidation, and that would be a little bit more characteristic for a bacterial process, although Mycobacteria fungal could look like this as well. but you would really worry about a bacterial process. And so what we actually found was, that was the imaging in our case. And sure enough, the diagnosis was Streptococcus pneumoniae, which grew on our blood cultures. A thing to note, this patient, again, these are pictures from that case, actually had purpura fulminans, which is a very severe systemic manifestation or rash that you can see with these patients. It's usually present at the time of DIC and emphasizes just how sick this patient was and how sick patients can be with severe strep pneumo, especially if they have immune deficits like he has for antibody deficits, because this disease can really progress quite rapidly. And unfortunately, that's what we saw in that case, was that patient's disease progressed very rapidly. But it provides a few important take-home points. One, common things are common in the immune compromised. So that patient had a lot of immune deficits, but ultimately had strep pneumo, which is still the most common bacterial cause of pneumonia for anyone that's walking in the door with a severe pneumonia. And two, respect the virulence of strep pneumo, and specifically for patients with those deficits that we discussed. So if we move on to our next case, now we're going to talk about a patient with RA, stabilized for 6 months on a TNF-alpha inhibitor and some steroids, who presents with 3 weeks of fatigue, dry cough, and increasing shortness of breath. She was admitted, and you see a quick escalation in her oxygen requirements. And so again, now we're looking at a different host. We're looking at someone with underlying autoimmune disease, which means that their immune system is not functioning normally in best of circumstances. And then they have a targeted agent, TNF-alpha inhibitor, but also are still on steroids, which brings up some questions, or at least it should. And these are the sort of questions that I might ask if I were in the room. Has she received any other immune suppressants recently? We mentioned rituximab in our last case. Rituximab has effect for 6 months. And there are other long-acting injectables like that where the immune effects are going to be seen for a much longer period of time. So making sure you know not just what they're taking today, but what have they taken over the last year? How is that changing? Are they increasing in immune suppression? And what is that in response to? Is it because the disease has been manifesting in different ways? We're having new symptoms, etc. These are all going to be pieces that are going to help you put together this puzzle. But it also brings up the question of how immune suppressed is this person? And I would say it's actually these particular patients with autoimmune disease, are some of the hardest to quantify. So if you ask me, a solid organ transplant recipient, you may have heard this before. I don't know what degree of solid organ transplants you do at your institution, but or exposed to, but abdominal transplant, liver, kidney is generally going to be lower immune suppression than heart and lung. Of them, lung generally is at the highest end of immune suppression. You may sometimes see small bowel or intestinal transplant, that tends to be at the same level as lung. Those are tissues that require a lot of immune suppression to prevent rejection. And so you kind of have a framework of knowing, okay, based off this patient, I know at baseline, they're going to be higher risk or lower risk. And then I might ask questions about how their immune suppression is changing, if they've had any signs of rejection, etc. If you move to the stem cell population, you're going to think about are they an auto transplant where really the main risk is just in that time of transplantation when they're getting that high dose chemotherapy that's going to be rescued with their own immune system? They're much less immune suppressed than an allo, which is certainly going to be higher risk because of the risk for graft versus host disease, and the medications are going to use to help prevent that. And then if you have someone, especially with bad graft versus host disease, lots of medications, then they're going to be very high risk. And I note that these are on a line just to designate that the overall risk compared to one another, but it is hard to compare solid organ. I'm not attempting in this talk to compare solid organ versus stem cell, just to give you a sense that you can kind of put these things on a line and know how immune suppressed your patient is compared with others that fall into that category. With neutropenia, your big question is how long have they been neutropenic? So most of our solid oncology patients that are getting treatments for like a breast cancer or lung cancer, they're usually not going to be neutropenic for more than a week. And therefore, they're going to be on the lower risk spectrum for the most part. Once you start hitting 10 to 14 days, you start worrying a bit more. And then when you go up to 21 days, you become a lot more worried about some of the most atypical sorts of infections. And generally, when you start getting to the far end of the neutropenia category, you're talking about patients with leukemia, patients with myelodysplastic syndrome, etc. So that's how we can start to put these things on boxes, and that'll come up later with some of our other cases. But my point here is that you can't really do that with disease-modifying agents for rheumatic disease. There's a little bit of a black box, and comparing the two them is difficult. I will say there's some NCCN guidelines that are used in really for those that also overlap with oncology use, but they have some wonderful tables and can be applicable for this population. I'll show you a couple of examples of that. There are a few of these drugs that are so notable they come up on your exams. So TNF alpha inhibitor infliximab is one of those. And so I would ask you to kind of think in your mind which of these infections or risk are increased with infliximab. And if you are having trouble because you feel like there's a couple, you're right. The correct answer is actually E, all of the above. And we see, at least at UAB, we see a lot of histo associated with infliximab use. Certainly, you want to screen for tuberculosis before starting this agent, and because of that known risk. And you also like to know about Hep B status because of risk as well, although we usually don't pre-treat for that. And then PJP is going to become relevant, of course, in our discussion. So what about steroids? Because steroids are generally thought, of course, to be very immune suppressive and not very thoughtful in how they're immune suppressive. And so it is essentially not just what dose you're on, but how long have you been on that dose and what dose were you on before. So there's a cumulative effect with steroids. Once you hit 10 milligrams, that's kind of the magic number that says that this is higher dose, your infection risk really goes up. If you're just talking about steroids alone, for PJP specifically, a lot of people will consider prophylaxis at 15 to 20 milligrams. But when you start adding in the underlying disease, when you start adding in the other agents they're on, it can be a little bit harder to put them on a scale. And so I point this out to say there is actually, you might find some reviews. So this happened to be a review specifically in RA and kind of the patient that is mirrored in our case, showing what the actual risk of severe infection was based off which agent they're on. Certainly high dose glucocorticoids is the highest risk, but even low dose is up there. And then when you start adding on low dose plus a TNF alpha inhibitor, again, you're starting to have additive effects. And so if you come back to our case and just think about what we have more of a subacute presentation. It's been 3 weeks. There's some nonspecific symptoms associated with it, but it seems like dyspnea and hypoxia are major features of this case. And then we show the CT scan. And I hope if you had kind of a differential starting in your mind, this CT scan is helping to solidify that for you. What you see is a lot of diffuse ground glass. And you actually see a couple of what are called nematoceles, which are pathognomonic kind of findings that you can see in the lungs, or a little cyst, if you will, which helps to denote the name of this pathogen. So this diffuse ground glass picture with these little cyst involvement would make you highly concerned. And before I give you the answer, sometimes we'll play this game on rounds where we'll ask people to really commit. Let's say you only have, you can only send one test to confirm your diagnosis. We're not going to send out 15. We can send out one. What would be the test that would best support your presumed diagnosis? So I'll let you commit that for yourself. And I would suggest that this pattern and this cyst is really concerning for pneumocystis or PJP. The diffuse ground glass that you're seeing would be the most common finding. Again, the cyst is a little bit of a specific finding we don't always see. You can also see viruses that would present like this. You could also see atypical bacteria like mycoplasma. And specifically thinking about PJP, beta-D-glucan can be a test even in this population, non-HIV population, that'd be very helpful in saying that is what's going on. So different places can have beta-D-glucan as a send out. Sometimes it's not as helpful in real time. You might have to make some empiric decisions, which I think the background in this case would make that reasonable to empirically treat. But beta-D-glucan could be an extra test that would help to improve your post-test probability and really confirm that diagnosis if you're not able to safely get a respiratory specimen to prove it. So Pneumocystis jirovecii, just a brief background on that pathogen. It is actually, a lot of people wonder, where does it come from? It actually spreads person to person, and there's many people that have asymptomatic colonization. They've shown that in autopsy studies from like motor vehicle accidents and other things. But you essentially don't have symptomatic disease unless you have a significant underlying immune deficit. Usually dry cough and hypoxia are kind of out of proportion to other signs and symptoms of infection. And when you think about what conditions really put you at risk, solid organ transplant, we prophylax for the first 6 months, stem cell transplant, 8 months to a year. Heme malignancy, it kind of depends on the underlying agent. That gets back to those tables, which I'll show you here in a bit. We talked about steroid use. And then really it's things that impact cell-mediated immunity. You can start to think about, would this pathogen be something that you might see? This is an example of that table I've been referencing. So this is just one like box from it, but you can see it kind of labels the agent, JAK inhibitor. It tells you what it is. And then it includes several of the pathogens that people might expect. These are things that you might think about if someone presents with an acute illness. These are pathogens that we've known have caused illness. And then the final part of the table talks about what they actually recommend for prophylaxis. And so as you see for JAK inhibitors, for example, although PJP is at risk, it kind of is PJP plus additional risk factors that might add to that. So are they on another agent alongside the JAK inhibitor that would make you concerned? So that tables can be both helpful when you're managing the disease on the front end to try to prevent, but also helpful when you're admitting someone overnight and you're just wondering what pathogens have types of infections have occurred on this agent. So just brief about lab testing. So, I mentioned beta-glucan was something that we could utilize in this case. It's something that's in the cell wall of most fungi, so it's definitely not specific for pneumocystis. It can be elevated in a lot of agents, but with that kind of pattern of lung involvement, pneumocystis would certainly be an infection of concern. It could be mirrored by other things, and again, additional testing might be reasonable to rule out things like histo, etc. The sensitivity and specificity is in about the 70 to 80% range, so it's not perfect. Things to know about false positives. Blood transfusions and IVIG are most common. I get a message about IVIG and then a positive beta-glucan probably like once a week. So that's a pretty common thing that can occur. Dialysis, it does depend on the dialysis membranes, and it's not true across the board. So you might ask the group that, if there's a case that's complicated, you can actually discuss with the dialysis group and they can tell you if the filters that they use might put someone at risk for this false positive. As far as LDH, it's not as helpful in immune compromised patients as it is in HIV and other IC populations. Part of that is because a lot of these underlying disease might lead to an elevated LDH. And so it's harder to say that that's specifically related to PJP versus other factors. And then PCR testing is helpful. We have PCR testing available at our center from bronchoscopy. It is worth noting that, as I said, PJP is actually passed person to person through asymptomatic lung colonization. So if you don't have high pretest probability, you can see some false positives. So you would want to make sure you're sending it in cases where the patient has clinical evidence of PJP. Just to get you a few quick hits on the testing spectrum, when you start talking about fungal testing, one of the things that comes up a lot is how hard it is to diagnose mucorales. They have a negative beta-glucan, they have negative asparagine. There's a lot of our typical testing is negative for them. There is another pathogen that can have negative beta-glucan even in disseminated disease. It's actually not true across the board, but it's more common to. You definitely can't exclude the infection just because the beta-glucan is negative. And that answer is Cryptococcus, actually. So the other pathogens here, Aspergillus, Histo, Candida, at least with severe infection, disseminated infection, you would expect a beta-glucan. Crypto can have it, but often is actually negative as well. So for our case, again, with this subacute process, the prominence of the hypoxia and the findings of ground glass with the nematoceles, pneumocystis is the answer. So take-home points from this case, again, these conditions are heterogeneous, and you're going to have a cumulative risk as you add on agents. We talked about the clinical presentation of PJP, and we talked about beta-D-glucan and its use in PJP. All right, keep rapid fire. We're going to go to another case. So this is a 60-year-old with a lung transplant. A little over a year ago now, interstitial lung disease was his underlying reason. Has had some rejection, and so had some increase recently in his immune suppression. Has had a malaise and a headache for about 4 weeks with some fevers, presenting with cough and a little bit of dyspnea, requiring supplemental oxygen. So again, we talked about kind of risk here. So this is a lung transplant with rejection, so on the high end of spectrum. And note that really a big part of what you're trying to control is cell-mediated immunity. It's going to impact both, but remember, and you might hear if you take care of these patients, if it's more of an antibody process, you might hear that it's antibody-mediated rejection. If it's more of a cellular process, you may hear about cellular-mediated rejection. But remember that the helper T cells are actually helping on both fronts. They're helping to recognize pathogens and to stimulate the B cell response. And so although our immune suppression works on both sides, it's a little bit more targeted to our CD4 and CD8 cells. And so there's actually some members of the herpes virus family that we worry a lot about in transplant. And really any of these bacteria or these viruses can be problematic. But I gave you a little bit of clue, and this is the thing that I see on MixApp. This is the thing that I've seen on boards, is to recognize CMV and its pathogenesis in transplant. And there's a lot of things that suggest CMV in this case, right? We have malaise. I mean, clinically, you have kind of a mono-like syndrome of malaise, headache for several weeks with a fever, and now actually some concerns that may be developing a pneumonia. Other things that you might want to know. So CMV is all about risk, and so in this case, you have a positive donor, a recipient negative. So that means that the patient had not seen CMV, the immune system was not aware of CMV until they got their organ donation. But CMV is going to be transmitted at the time of organ donations because it lives in our myelocytes, which are all throughout our organs and everywhere. And so the patient essentially became infected with CMV at the time of transplant. We will usually do prophylaxis for different periods. This patient was on 12 months of prophylaxis per that hospital's protocol. And so we know now that they are at high risk for CMV and they were on prophylaxis, but this is 14 months out and their prophylaxis was only for 12 months. So their prophylaxis was stopped. And so just a quick reminder, CMV, like VZV, like other herpes viruses, it lives with you. It never quite goes away. So if you have antibody testing that's positive, it means that you have a latent infection that can reactivate. And it can happen even in recipient positive patients. So you could have had CMV controlled for your whole life until your transplant, and then it becomes more of an issue, but it's at highest risk in the scenario that we just discussed. And what's worth noting is that CMV used to be a big problem right after transplant, and then we started doing CMV prophylaxis. This is more mirroring like kidney transplant or liver, where they only do it for a few months. In lung, they do it longer. So in our case, we said 12 months. But regardless of how long you do prophylaxis, what that does is it shifts when the disease presents. And one thing that we see a lot at our institution, and one of the reasons I bring this up is, again, patients come from 4 hours away for their kidney transplant, let's say, and then after about 6 months, after they've stopped their immune suppression or their prophylaxis, is when they're primarily following close to home. Maybe they're coming to the transplant center every 3 months or every 6 months, and it's their primary care doctor who's taking care of them. And so I've seen several cases where someone has had a fever for several weeks or kind of non-specific mono-like symptoms that is very concerning for CMV, but that they just weren't aware to think about it. They haven't been trained on how to take care of transplant recipients. And so it took a lot longer to diagnose than it may have had it happened sooner post-transplant. And so what you see with CMV, you can see that mono-like illness, you can see tissue invasive disease. The most common tissue invasive disease is diarrhea when it affects the colon. Pulmonary disease is more common in lung transplant. And then bone marrow involvement where you'll see cytopenias. And then see, we worry a lot about CMV too because it causes rejection and lots of indirect effects, which are beyond the scope of our presentation. So this is what our patient's imaging looks like. Again, we're seeing kind of diffuse ground glass. And as we talked about earlier, that diffuse ground glass could be consistent with a lot of things, but certainly would be consistent with a viral pneumonia. And so, again, thinking about testing, how are you going to prove this? So, what is the best test to send for CMV? And I hit the button so you get to see the answer. But really, CMV quant testing, so DNA level testing, is going to be the most helpful thing. You want to see how high that viral load is, and you could send that from the blood. Um, antigenemia is not done as frequently because it's too heterogeneous across laboratories, and so it's just not as reliable. Antibody testing is just going to tell you things that you already know. Viral culture is expensive and not done. And a T-spot immune assay might help you to understand how the immune system is starting to react to the CMV, but doesn't tell you if there's active disease. And so the CMV quant is what you'd want to check for. And so that was tested in our case, and sure enough, that CMV quant was really high, 126,000, and so we have confirmed CMV. So some take-home points from this case: CMV is common. It's the highest yield pathogen for boards. It's probably the highest yield part that we're talking about today. Its reactivation often kind of happens post-prophylaxis in the next 3 to 6 months. So that would be something to think about. It also can show up if you've had an increase in your immune suppression. So a rejection episode at the 2-year mark, 3-year mark, or if you have another infection that your immune system is having to face and focus on. And so those are all kind of potential nituses that might help CMV to show up when you had done well with it before. Again, CMV pneumonitis can happen more often in lung transplant than other SOT recipients. Thankfully, that's a very severe complication, and so thankfully we don't see it nearly as often. Case 4, and this is my biggest case that I have left, so I think we'll be okay on time. My last case is kind of a quick nod, and then there's a total of 5 cases. So case 4 is a 65-year-old with fever in the hospital. They're on day 22 of admission because they have AML and they're getting induction chemotherapy. And they had some shaking chills with fever, but otherwise feel well. They had a little bit of a cough, some scant hemoptysis, but otherwise no new symptoms, and their neutrophil count has been at 0 for many days. And so I mentioned earlier, when you talk about neutropenia, how long you've been neutrophilic is really important for thinking about what types of pathogens you might be at risk for. So the first pathogens are bacteria, and as you know, they can come whenever. You can see gram-negative bacteremia. We see a lot of streps because of mucositis and other things that happen in the oral GI tract. That can happen from day 1, essentially. The yeast, specifically Candida, usually you're starting at about day 10 where that risk really becomes higher. Now, of course, you could have multifocal risk, you could have, broad spectrum antibiotics, have been in the ICU, etc. Other risk factors for Candida may compound the neutropenia, but neutropenia alone, usually about 10 to 14 days is when that starts to show. And then molds, usually is longer timelines, usually closer to 3-week mark when you start to really see molds start to occur. And we're in that timeline for our patient case, right? We're day 22. They had AML before. We don't really know. Their immune system was likely not functioning normal beforehand. And we've checked serum asparaglucosamin and beta-glucan, and both are positive. So just a reminder about that testing. So asparaglucosamin, again, part of cell walls. It's particularly noted to be a part of the aspergillus cell wall. And when it's positive, it suggests active replication, so active disease. Notice there is a lot of cross-reactivity, so you can see it with other pathogens. We see it a lot of histo here, so we see it a lot positive in the cases of histo. And you again can see it sometimes as a false positive, but in a patient like this with risk factors, it'd be hard to label that as a false positive. You can see the specificity there, pretty high, especially high if you make the cutoff 1, and different labs will usually report what their kind of level is. Sometimes they might say it's positive at 0.5, 0.6, but you might even put a higher cutoff of 1 to really confirm that it's a disease. If the case isn't clear, a cutoff of 1 really takes your specificity high to 95%. We have Aspergillus PCR testing available. Again, specificity is about 95%. Oftentimes doing the two in tandem helps to augment each other if you're in the right population. And this is the imaging of our case. And I hope this imaging is what you may be expected to see based off the line I was taken. You see nodular disease with surrounding ground glass. That surrounding ground glass is sometimes called a halo sign. You see multifocal evidence here. So this would be highly concerning for, it could be a bacterial process. It could be an atypical mycobacteria or an atypical bacteria like Nocardia, but molds particularly look like this. And classically for imaging, you'll see Aspergillus or mucorales with a halo sign on your board exams. So the question now is, well, what antifungal are you starting if you're concerned? You have positive aspergilloctomannan, you have nodular disease with surrounding ground glass. And I think the point here is that actually invasive aspergillosis is one of the few places where triazoles like voriconazole has been proven superior to amphotericin. So oftentimes voriconazole would be your first line agent if the patient hasn't been on prophylaxis. Posaconazole, isavuconazole are newer agents that have similar spectrum and equal efficacy to voriconazole. Those aren't listed here. But the ones I've listed, micafungin, fluconazole, those are more agents for yeast, not so much for mold. Itraconazole we use a lot for endemic fungi like histo, and then amphotericin would be preferred for something like mucorales. But in this case, we had positive aspergilloctomannan testing, and so it would make you think about Aspergillus. So again, take-home points, talked about the risk of fungal infection with neutropenia, and we talked about nodular sign, halo sign. Again, worry a lot about fungal process, but we literally just had a case this week in our service that everyone thought it was going to be fungi, and sure enough, it was Nocardia, which thankfully usually Nocardia grows on cultures quite easily, and the culture growth is what gave us our answer. So our final case, and again, this one will be a little brief, is a patient with non-small cell lung cancer, developed progressive shortness of breath and cough for 2 weeks, prompting their admission. So this is more of an indolent process. They were receiving a PD-L1 inhibitor, which is a checkpoint inhibitor, and this was actually held and some steroids were given because of that. And so then again, this is looking at those charts, those tables that I mentioned that you can find on the NCCN guidelines. And what you can see is if you actually look at the PD-L1 inhibitors, there's no clear increased risk of infection by the drug alone, but certainly it can cause a lot of itises that end up treatment with steroids. And when those steroids are given, sometimes that can lead to reactivation. And so here again, we have a subacute process. It's primarily dyspnea and no fever or infectious symptoms, only a mild leukocytosis with the steroids, which might prompt you to ask, well, does being immune suppressed mute the fever response? And this is something that's worth thinking about. I think it certainly can, but I also don't think it necessarily does. So there was a randomized controlled trial in transplant recipients. These are solid organ transplant that showed no difference in fever rates when like a documented bacterial or fungal infection was present between the transplant recipients and the matched controls. For hematologic malignancy and patients that are neutropenic, what we see is almost the opposite because they have such a limited immune system. They lean on cytokines and inflammatory response, so they fever all the time, even when there's not an active bacterial infection present. And so I think it depends on your host. It's definitely a worthwhile consideration. If you have other evidence of infection, it may be muted, but also know that we can certainly see fevers. And so there might be a little bit of reassurance if the rest of the pattern fits with a non-infectious process. And what you see on the imaging of this case with the PD-L1 inhibitor is some ground glass, but also you're starting to see some changes that almost look a little bit like interstitial lung disease, a little bit of fibrosis, some things that look like they're a little bit more chronic. That Lancet article that I referenced earlier, got some great tables, and some of those are showing different lung imaging and the different things that you can see in the lungs. And some of those, it includes quite a few actually, non-infectious pathogens. And so I would say this particular pattern that almost mirrors a little bit of an ILD, although it doesn't always look this classic, is what we often see with pneumonitis associated with checkpoint inhibitors. So my big take-home points from this case is that, the NCCN tables again are a great resource, and so I wanted to bring you back to them because they kind of cover that broad spectrum of illnesses that aren't easily defined in review articles, etc. And to think about these non-infectious causes of respiratory failure as well. So sometimes that requires our pulmonary team or other specialists to help us have a good multidisciplinary kind of conversation about what to do next. Because obviously treating with steroids when infection is a potential is going to lead to some concern. And so we often kind of talk together as a group and make decisions for our patients. So in summary, kind of summarizing our cases, common things are common, even in the immune compromised. These immune suppressive conditions are heterogeneous, but if you look at kind of how things are changing, that may help you. And if you can sometimes find good review articles or resources for specific types of immune suppressed status, such as cancer patients or patients with solid organ transplant. CMV is something to know about, especially for SOT, and you're going to see it more often because we're doing more SOT in the community. We talked about invasive fungal infections and when you see them. And then finally, non-infectious causes can also cause respiratory failure, and it often getting ID involved with pulmonary and other groups can help in those most complicated patients. With that, I kind of included, and happy to share these slides if people want them. These are some of those tables that I referenced from NCCN, just some screenshots so you can see how helpful they are, but you can also download the official tables. They get updated every year. And then some of the links that I kind of mentioned for helpful review articles for this population. I think I was able to still give us at least a few minutes. So if there are any questions, I'm happy to entertain them.
Walker. I'm gonna just turn to the audience and see if they have any questions, but thank you. Yes, and go ahead and press the button. Looks like you already are.
Hi, can you hear me?
Yes.
Okay, hey, my name is Deepan Oza. I'm one of the pulmonologists here. When you were talking earlier about the additive effects of immunosuppression on patients and timing of prophylactic antibiotics in people, do you have a practice that you use in terms of immunosuppression when you start patients on prophylactic coverage for PJP?
Yeah, it's a great question, and I think one that we're trying to formalize better in our institution. I mean, as an ID provider, I'm often actually responding more for secondary prophylaxis because I'm not the one that's starting the initial immune suppressive agent. I've taught with some of our oncology group and rheumatology group on protocols, and so we do have a few places where it's standardized. There's some agents that in where it's kind of indicated, but more often they do leave it up to the discretion of the provider and kind of weighing these multiple risks. And I'm not aware of a great risk assessment tool or anything else that really can help guide you in that. There are some decent review articles that have talked about overall risk of PJP, especially in rheumatic disease, etc. We have it standardized in our stem cell group. We have it standardized in our solid organ transplant recipient group. But when you get into rheumatology and other kind of monoclonal antibodies or treatments for oncologic disease, it's still a little bit dependent on the provider. And what I typically do when asked that question is do try to think about, multiple agents. If you have multiple agents that all are at risk for PJP, especially if one of those is steroids, even if the steroids isn't high, even if it's only like 10, that makes me a lot more concerned. And do know that the PJP outcomes are actually a lot worse in our population than HIV. And so it's actually a pretty high mortality disease. And so I think if patients can tolerate the prophylactic Bactrim and there's a concern, I would err towards that side. And that's what I generally do on the case-by-case scenarios that come up to me.
Thank you very much.
Any other questions? I have one question, and that relates to chest x-rays. And in terms of diagnostic imaging, how reliable are chest x-rays in patients who are immunocompromised? In other words, when would we necessarily just jump to getting a CT chest?
It's a great question. We probably jump to it faster than we need to. I think the population that needs it the most probably is those febrile neutropenias and the patients with concern for underlying invasive fungal infections, because that nodular disease can often be harder to pick up when it's smaller. And so in general, that's part of our workup for febrile neutropenia where they haven't responded to initial management. And we're still looking for a source, is to look at a CT chest, usually by day 3 or 5 of persistent fevers. For some of the others, like a bacterial lobar consolidation, I think that you can feel pretty reliable in that, at least as your initial management. And then it's more if things aren't responding as expected over the next 2 or 3 days, and then pursuing that extra imaging. And then when it comes to, some of the others like lung transplants, leukemias, I think some of those higher risk groups for pulmonary infection and other pulmonary processes that could be non-infectious, those are patients that we probably have a lower threshold. So we get a lot more CTs for them than we do for, say, someone with a kidney transplant or someone with, a rheumatic disease that's coming in with a more typical respiratory process. But yeah, I think we have the benefit of our having them done already by the time we see them often, as I'm sure you do too.
Well, great. I know we have reached time. We do have one more question but I realize that some people may need to go, but do you want to?
Hi, great talk. Can you hear me?
Yes.
I'm a rheumatologist, and I think one of my questions about this was, my practice has changed, especially after COVID, and more so with rituximab. And I saw one of your graphs where rituximab was right above abatacept and below TNF and JAKs. And I was wondering, what we have typically done when we have someone on rituximab, and I felt that they are the most immunosuppressed folks compared to other drugs. And those are the folks that I would even put them on PJP prophylaxis, especially if they have vasculitis, and they may even stay on it despite tapering off prednisone. And I'm just wondering if this is more like a personal thing, or should I not worry about it too much? I just feel like even the guidelines that ACR talked about were way more restrictive with rituximab compared to others, but I just want to hear your experience.
Yeah, I think I was actually trying to pull up, but it's several slides, so I think it's probably longer. I'm happy to share them with you though, if you'd like, because I actually did a more targeted talk specifically for rheumatic for patients.
Oh
My I did a specific talk for our department on kind of rheumatic disease and PJP prophylaxis considerations. And you're right, when you get into specifically talking about that, there's a lot more nuance there. It is just the B cell depletion is a big risk factor. And so rituximab, I guess my general practice is still rituximab alone doesn't necessarily buy it 100% of the time, but rituximab plus additional agents, often we're utilizing it. We just, I'm on general medicine, and that's where I kind of ran over from. We actually just discharged a patient with relapsing polychondritis that got a dose of Ritux and was going to go out on steroids. And even though it was going to be quickly dropped below the limit, below 20, we still ended up keeping them on PJP prophylaxis because of that combined risk. But there are, I think, nuances of the drugs that you're talking about that there's some good review articles that I could point you to that at least balance and weigh out this risk. I think the truth is we don't know. There's not a great study, and I think that's why the guidelines are not quite as clear. And I think it does lead to some confusion sometimes in provider variation.
Absolutely. Thank you. I would love that. I think also what I don't like about rituximab is it's every 6 months. So once it's in, there's no way to do anything except for IVIG if there's hypogammaglob. Whereas JAK inhibitors, they're oral, they're short-lived. You can stop it and hope their immune system will recover. So that is something that I use a lot to, decide and talk to my patients about when we pick.
Absolutely.
Yeah, and I'm happy to connect both of you. So just reach out to me. Yeah. Well, thank you so much for this talk. It was amazing, and I'm really impressed with the speed with which you gave it so clearly and cognizantly. But thank you so much for taking time to talk with us. That was really amazing, and I'm just going to give you a big hand. Thank you.
Thank you all again. It was truly an honor to be here.
Thanks, Jeremy.